my name is Michelle Morand, and I'm here with the cancer guy, Alexander Rolland. He wanted to come on and talk with you a little bit, or make sure that we got a chance to talk about an exciting new development, really. I'm not even going to say any more, Alex. Why don't you tell us a little bit about what's got you so excited right now?
Yes, thank you, Michelle. Well, this new study is going to greatly change how estrogen-positive breast cancers are treated. As you may know, when a woman is diagnosed with an estrogen-positive breast cancer, they typically get surgery, or they can have treatment before surgery to shrink the tumor if it's a really large tumor. That's referred to as neoadjuvant therapy. And then they get standard care, which is usually chemotherapy, or it can be anti-estrogen therapy. And when they develop metastasis, then they're given a class of new drugs, a new class of targeted drugs called CDK4/6 inhibitors. Now, there's basically three different CDK4/6 inhibitors: palbociclib, ribociclib, and abemaciclib. And they were made based on each other's failures. So palbociclib was the first one made. And then the makers of ribociclib wanted a drug that worked when palbociclib didn't work. So they created it, designed it around certain resistance mutations that cause resistance to palbociclib. And then the drug makers of abemaciclib wanted a drug that was going to be better than ribociclib. So we have these three CDK4/6 inhibitors. They're only used in the metastatic setting, but they've been game changers for women with estrogen-positive breast cancers. It's a targeted therapy that results in reducing the amount of the CDK4 and the CDK6 proteins. These are proteins called cell-dependent kinases. And what they do is they allow the cell to go through, there's sort of checkpoints that allow the cell to go through certain cell cycles. If you have an overexpression of these proteins, then these cells can go through the replication process unchecked, even if they have mutations and alterations. And so these drugs limit the ability of the cell to do that. So what has really changed is this new study called the monarchE study. And I'd like to talk to you about that because it's really been a game changer. And what the monarchE study did was they wanted to take a subgroup of breast cancer patients that had what they called poor prognostic factors. And those were defined as, having a large tumor, over 3.5 centimeters as your primary tumor, or having, multiple lymph nodes, or having something called high Ki-67, which is something called the proliferation index, or, having other features that really would suggest that the breast cancer is going to come back sooner rather than later. And so I'm just going to share my screen with you right now. These were women that had greater than 4 lymph node metastasis, or 1 to 3 lymph node metastasis, and either grade 3 disease or tumor size larger than 5 centimeters. And what they were given is they were given abemaciclib, or they're given a standard care, which is an aromatase inhibitor, that's an AI, or tamoxifen. And then they were followed for many years to see what the recurrence rates were. And so I'm going to share the recurrence rates here. And as you can see, they were quite significant. And so what this refers to disease-free survival. So the top chart here, this is the placebo, which was a standard treatment, tamoxifen or aromatase inhibitor. And this was the abemaciclib plus aromatase inhibitor. And so at 3 years, as you can see, the change was fairly significant. And there was basically a reduction of what is said as a 33% reduction in risk of having metastasis reoccur. And so this is a duration of 2 years. So they did the drug for 2 years, but you can see that the benefit went on quite a bit further than that. And so the whole difference at 48 months was 79.4% versus 85. So these women in the red definitely have a lot less recurrence of disease. And they also looked at the Ki-67 to see if that made a difference. I'm just going to share that. Ki-67, they found it was prognostic, but it did not change the benefit. So if you have a high Ki-67, it means your cancer is growing faster and it's more aggressive. And low Ki-67 means your cancer is less aggressive. And so, as you can see here, if you had a high Ki-67, you still got a significant benefit right here. That's 83.6% versus 74.7%. And that's at 48 months. And if you had a low Ki-67, then your chance of being cancer-free at 48 months was 88.8% with this abemaciclib early on versus 82%. So, some people may say, well, that's 6% difference. That's a, fairly significant difference over the long term. But what I'd like to show is there's another new study, and this is an update. And what they did was they said, okay, well, let's look at the subgroups of these patients, and let's see, okay, we know that this abemaciclib given earlier, rather than waiting until the patient is metastatic, can greatly reduce the risk of an aggressive breast cancer, metastasizing. Let's look at the difference between women that had neoadjuvant treatment, like chemotherapy or whatever. A neoadjuvant meaning it was prior to their initial surgery in order to shrink the tumor, versus just having adjuvant therapy, in other words, post-surgery. And if you look at the bottom here, you can see it at 2 years, for women that had neoadjuvant therapy only, and this is what this is all about here, is the 2-year difference was 82% versus 89.5%. So 89.5% of women were metastasis-free at 2 years versus 82.8% with the standard care. However, and this is an important thing that I find a lot of medical professionals do not look at, and these are called the survival curves, or we just call them the curves. So often clinical trials focus on what's called the median, and that would be the 50% mark. So, the progression-free survival median, for example, that's when 50% of the patients in a trial have recurrence of their cancer, and a median overall survival is when 50% of the patients in the trial die. So sometimes that doesn't always look that great. And I've had doctors say, well, that's not much of a difference, considering there's potential side effects from doing abemaciclib early. But when you look at the difference here and you look at the actual rates, I mean, right here, you can see this is at 33 months, this is dipped down to, just under 70%. Whereas up here, it's like still 85% or so. So right here, so the 2-year rate is right there. But when you go further and you look at extending it, you see, okay, sure, the 2-year rate is not much different. Well, there's a nice difference between the two, but look at the radical difference between these two here. Yeah. So, under 68% of the women were not cancer-free versus 80, at least 85% here. So this is what you need to look at right here.
Long term.
So long term, and you need to look at these survival curves. And most medical professionals do not look at that. They'll read the headline, they'll say, oh, the 2-year survival rate was 80 versus 87.2. Sure, that's good, 7% difference or 6.7% difference. But really, you got to read the study, and you got to look at the long-term survival and the long-term disease-free survival in this case. So, here's 2 take-home messages. If you have an aggressive early breast cancer, definitely push for neoadjuvant therapy. That means treatment prior to surgery. And also make sure you get this abemaciclib right after you finished your surgery. It's going to make a huge difference in the long-term survival and the long-term cancer-free survival. So really, that's the take-home message here.